Hey, welcome to Medical Stuff. My name is Mark Shamalama Ding Dong Frankham, and that is Chris. Oh my God, is he really that tall? Finkston right over there. How you doing, man?
I'm doing good, but actually I do want to make a comment on that. And you're going to know this too, Mark. You're also tall. If you're not tall, we actually don't need you to tell us that we are.
In all fairness, though, that would take away our ability to reference how short people are.
Yeah, I don't know. I feel like short people get what they deserve. And the best part about it, though, is when people come up to me and they're like, "You're tall." My favorite thing to do is to be utterly surprised when they tell me this, as if they have given me a piece of information.
I was completely unknown to you before they walked up.
Completely new. So, what are we talking about?
Right now, we're talking about how tall you are, but the show is going to be about respiratory distress and diseases.
Yeah, actually, let's just go back to how tall I am. That's the show.
Yeah, because you were a narcissist, sir, and it's all about you.
This is what you've tuned into for today.
Yeah, narcissism with Chris Finkston.
Mm-hmm.
Excuse me. So this is probably a good time to do the show because both Chris and I are currently suffering from some sort of upper respiratory thing going on.
Yeah, and I have no desire or motivation to edit out the coughs and hacks.
Nope. We figure it adds to the spice of the show.
Yeah, absolutely. I think people get to know us a little bit better.
Yeah.
On that.
You can tell a lot of person by how they cough. You know.
Well, actually, you can, which is exactly what we're about to talk about. So respiratory stuff. Respiratory diseases is actually one of the more common categories. I would say COPD, which we're going to hit, is one of the more common respiratory diseases.
But COPD is not a disease. It's
That's
a descriptor
true.
of a group of
It
diseases.
is a group. It's like a disease party.
And so thank you for perpetuating the myth.
Yeah, it's not even a disease party. It's like a disease hangout. I don't think there's enough there to constitute a party. It's really like
anyway. It's a grouping of respiratory problems. It's not a disease in and of itself.
Yeah, but I think there's 3 million new cases each year of COPD.
Of COPD or emphysema?
COPD.
Of just random. Okay, I can buy that number.
Yeah.
Are you making that up? Or you?
No, I'm not making it up.
Okay, did you look that up?
I mean,
could you
the internet might
sources?
be making it up, which is totally.
Could you
level.
cite sources for that number?
It is literally the first result on Google. It's literally like the first thing. It's not even a result. It's where it just summarizes the page for you so you don't have to click. That's
yeah, but is this like a legit WebMD or science page?
Yes, it
or
is.
was this
It
like
is.
Breitbart?
No. It's not like a blog post or anything like that. It was a legit source, yeah.
Okay. Now, if you'd gone and read more in depth, would you have found out that they were talking about emphysema versus just a general COPD?
No, it was very clearly COPD.
Okay.
Yeah.
So COPD is a grouping of respiratory problems. There's emphysema is probably the one that is most commonly confused with COPD. People who tell me on scene they have COPD, I ask them how much they smoked because they mean emphysema.
Yeah.
But what COPD is, it's chronic obstructive pulmonary disease, which is more of a descriptor of what's going on rather than an actual individual disease. Asthma, for example, is COPD. Chronic bronchitis is COPD. Bronchiolitis is COPD.
Now, the most common pairing when they're talking about the group does include emphysema and chronic bronchitis. So that's kind of where that confusion comes from. So it is understandable. And one of the things Mark mentioned, you did mention smoking. In terms of emphysema, I think it's, although not all people that smoke develop emphysema, about 90% of people who do have emphysema are previous or current smokers.
Right.
So it's a huge risk factor.
Oh, yeah. No, it's definitely the leading factor of causing emphysema. So what is emphysema?
Well, so if you look at your lungs, look at your lungs.
Don't try and look at your lungs. Look at somebody else's lungs.
Yeah, it's going to get really loud and screamy on this podcast here in a little bit. So if you take a look at your lungs, they're basically sacs filled with more little sacs. If you can imagine taking a pluck of grapes and putting them in a grocery bag, that's kind of the structure of the lungs. Okay.
With a bunch of tubing hooking them together.
Absolutely. And so
that tubing could be a straw. It could be a celery stalk. Just to stay in the conversation.
So I just
we really got to start doing this when we both feel better and had more sleep. So
I don't know. I kind of like the way this is going so far. Actually, I've enjoyed it. So if you're looking at that picture of the lungs, what happens in emphysema is the grapes essentially start to break down, and what you end up with is instead of lots of little grapes, you start ending up with these grapes breaking down, and they end up creating larger air spaces, and that reduces the available surface area in the lungs for oxygen to transfer into blood. The other thing it does is it also creates scar tissue, And lungs, which are normally these nice, elastic, stretchy bags of tissue, which they need to be because they have to inflate and deflate, they don't do that as well anymore. So you lose capacity. In terms of surface area, if you think of like how a radiator in your car is built, you've got lots of tons of little tiny fins in there to increase surface area. And if you take a look at your lungs, you're supposed to have lots of little tiny grapes, if we're going back to that analogy, to also have more surface area for the absorption of oxygen from the air into your blood. And likewise, the expelling of CO2 from your blood back out. The less of those little grapes you have, the less surface area you have.
Now, also, what happens is that the grapes and the ends of the celery stalk, they get very small.
Yes.
And so they become irritable and they constrict. And this is where you get your wheezing sound. This is where you get your wheezing sound.
This is wheezes. Nope, it's not. This is wheezes.
Okay, so what this does is it sounds a very high-pitched whistling sound, and you can have wheezing on the way in, but not on the way out, or vice versa. And
that's actually what you heard in that sound clip there, is you actually heard what we'd call expiratory wheezes, where that's wheezes on the way out.
Right. So one of the most common medications to treat this that we carry is albuterol and Atrovent.
Mm-hmm. And albuterol is pretty common. That's what you see in the inhalers, in the puffers.
And the rescue inhalers.
Yes.
Because there are daily inhalers that you can take for these symptoms that are not meant to be used in an emergent situation.
Mm-hmm.
Albuterol. Now, there's also Xopenex, which is a form. It's actually a levalbuterol, if I remember correctly. And this is just a different form of it. They've turned part of the molecule a different direction. And they use it a lot in children who are not responsive to asthma medications.
Now, and I'm just asking this honestly, Mark, because I'm not sure. Does Xopenex have... So one of the side effects of albuterol, and if anyone's ever had a toddler that's had to have albuterol, it does increase the heart rate and tends to get them a little bit hyper. My understanding is that Xopenex doesn't have as pronounced of an effect in that regard. Do you know if that's true?
I do not know if that's true because I've never actually given Xopenex.
Yeah, well, we don't. And
some
we don't
services
carry it.
do carry it, but we do not.
Yeah,
I am looking it up right now.
The Canadians carried Xopenex.
Let's see.
Well, and while he looks that up, another drug we commonly carry is Atrovent, also known as ipratropium. If you've ever had something called a duoneb, this is it's albuterol and this medication. So what Atrovent really helps with is where albuterol will widen the airways when it's inhaled. If your airways are constricted, the albuterol has a hard time getting down to the sites that it needs to get to do its job. What Atrovent does is it helps with that. So by adding Atrovent to albuterol, it allows the albuterol medication to actually get a little bit deeper in the lungs. Atrovent by itself doesn't do a whole lot. It's not given by itself, actually. It's always given with albuterol. Any luck on Xopenex?
Yeah, so there are a whole series of them, one of them being anxiety or nervousness. Or
for side effects?
For side effects. Nervousness, anxiety, but what they do say is a fast or pounding heartbeat is a reason to contact your doctor, and it's a serious side effect. So you can have it, but if you have it, you need to be very concerned.
Okay, gotcha. All right.
So along the lines of emphysema, we have asthma. Now, asthma is treated very similarly to emphysema because what we're trying to do is asthma is a similar effect from a different etiology. So, ooh, I know.
I like that word.
I looked that up while I was doing the Xopenex thing.
Is that you really weren't even looking up Xopenex?
No, I'm looking
like
up
cool
etiology.
Words.
Yes, words to make me sound smarter. With asthma, you have the constricting of the bronchioles, and you're trying to open it up. So we do give the albuterol and the ipratropium, it's also called Atrovent. Yep. And in both these cases, we can give dexamethasone or a steroid of some form.
And the bronchioles are those little pathways. If you go back to that grape in a sack picture, the bronchioles would be the stems that connect out to the grapes.
Right.
Those little tiny pathways.
So there's not a whole lot of room there. So if those constrict,
yeah,
then that's where you start having your problems.
Sort of out of room.
Right.
So, and those things constrict in the sense that there's a couple ways that you can narrow those airways. In asthma, though, what we're talking about is there's the smooth muscle, if you will, or I guess it's more like rubber bands that surround those airways, and they can relax to make those airways a little bit bigger, such as in like a fight or flight response to get more oxygen. And they can also constrict, which is a defense mechanism for your body to prevent disease. But if it constricts too much, you end up with an asthmatic reaction and reduced airflow to where it needs to be. So what albuterol does is it goes in there and helps those.
Right, relaxes those muscles so that you can get more air through. So, yeah, that's asthma, that's emphysema. Both are COPD, which brings us to chronic bronchitis. Now, Chris mentioned earlier that emphysema patients generally are lumped in with COPD and chronic bronchitis. One of the problems with emphysema is your lungs aren't able to clean themselves out naturally. And so you constantly have a lot of phlegm, mucus stuck in your lungs, and that routinely becomes infected. Generally, you also find that these are the patients that are still smoking with emphysema. And so they're introducing those toxins still into their lungs when their lungs can't handle just normal daily life. Now, with emphysema patients, one of the things you also see is these patients will generally wear oxygen, either as needed or all day long.
Right.
And that's because their body can't process that oxygen into the bloodstream enough that you actually have to add extra oxygen just to keep them at a semi-normal level.
And Mark can tell you just as well as I can. I can't tell you how many scenes I've been on where you have these. Well, I'm actually going to say, I would say impressive networks of oxygen tubing just strung through the house.
Oh, yeah. You could go check the mail or walk to the corner store and your oxygen tubing and your bottle never leaves your house.
Right.
But then again, we also have the infamous almost blew my nose off because I was smoking with my oxygen on.
That's right. There was a patient actually near. Are you referring to that guy?
Well, I'm referring to a guy.
Yeah. Not any specific guy,
yeah,
of course.
No, I've run more than one call like this where you show up and their oxygen tubing is actually burned off their face and they have small singe marks around their nostrils.
Yeah.
So
that actually happens.
Yeah, one more reason not to smoke, especially when you have emphysema.
Emphysema and you're on oxygen.
Right. So another form of the classification could be well, on the screen it says CHF, but we're going to go congestive heart failure. So
that was a phonetical expression of the
CHF.
abbreviation CHF.
So with CHF, what's happening is that your heart is not able to pump blood out of your lungs as fast as it's pumping it into your lungs.
Yeah.
This causes a back pressure. One of the first signs of congestive heart failure is dependent edema. The lowest part of your body will start to swell up while your body tries to find a place for this extra fluid. In fact, one of the ways, if you ever hear the term pitting edema, you push on there, you take off, and you start counting 1, 1,000, 2, 1,000, 3, 1,000. If you get to 3 before it comes back to its natural state, that's +3 pitting edema.
I think the worst pitting edema I ever had is I pushed down, I got to 3, and then I went and did some other stuff, and I looked back, and I could still see my fingerprint.
Right.
I'm like,
oh yeah,
Jesus.
it can be bad. And remember, it's the lowest point in the body. So I have had a patient who, it was in the buttocks because they were in a bed with their feet raised. So their butt was actually the lowest point on their body.
And that's how you get that J-Lo booty.
It is. One of the ways, anyway. So once your body is unable to compensate with this by what's called third spacing, what we've been describing is called third spacing of fluid, it will eventually start building up in your lungs, and your lungs will start filling with water and fluids, plasma, stuff like that. And I have walked in on homes, and if you've ever blown air through like a pop or milk, that's what it sounds like, or an old coffee percolator.
Are you talking about the lung sounds themselves, or just when you walk in?
No, just the lung sounds themselves, yeah.
Yeah, actually, here's an example I can play. And that's what we would hear through the stethoscope when we're listening to someone's lungs. So yeah, so that's the interesting thing about congestive heart failure and why it's actually something that can really trip up neuromedics. At its core, it is a heart problem.
Right.
It's not at its core. It's not a respiratory problem. And so yeah, but one of the worst scenarios though is a lot of the same risk factors for congestive heart failure, such as smoking and age, are also the same risk factors for COPD and emphysema.
Right.
So it's not terribly uncommon. In fact, I will say the worst respiratory calls I've run, the hardest ones, are ones where we'll get there and I can barely hear any air movement, and what I can is a whistle.
Mm-hmm.
And we have this massive constriction on someone with a history of COPD. Well, what I'll do then is I give them the albuterol that we talked about earlier, and that opens up those airways. And
Just
then
so you can hear the fluid.
yeah, and then all of a sudden they don't seem like they're getting any better. And then you listen again. Now that the airways are open, I hear fluid as well. Because think about it.
Now, the downside of that is once you release the pressure, I mean, you have to do it.
Right.
But once you release the pressure of the asthma-like effects, and I've heard it referred to as cardiac asthma.
Right.
It's an asthma-like effect secondary to a cardiac problem, such as CHF. Once you release that pressure, the lungs can fill up quickly.
Absolutely.
And you can have a flash pulmonary edema.
Mm-hmm. And yes. And I think one paramedic that I used to work with, maybe his name was Mark Frankham, used to say this, and this is true. On a bad respiratory call, you don't run a bad respiratory call, you chase it.
No, that wasn't me.
That wasn't you?
No.
It sounds good, though, doesn't it?
I say that most patients will circle the drain, and CHF patients go straight to their hips. Because a CHF patient will crash on you quicker than anybody.
Yeah. Yes,
Because
they will.
they will physically become too tired to breathe.
And you're also taking into account that you have someone who has congestive heart failure. Well, that's usually due to some sort of cardiac disease. Well, it is due to some sort of cardiac disease in the past. So now you're going to take this diseased heart and deprive it of some oxygen. So the potential for these people to have, in addition to the fluid in their lungs, to have their heart suddenly say, screw it, I'm out, is not terribly uncommon at all.
One of the worst CHF patients I ever saw, I believe your dad was on scene. And this lady, it's called fulminating CHF. And you have so much fluid in your lungs, you actually have just a fountain-like effect of sputum just fountaining out of the person's mouth. Like they're vomiting constantly.
But it's not vomit.
But it's not vomit. It's
Wow.
it's sudsy lung fluid because it's full of air and it's got enough viscosity that it actually holds little pockets of air like bathroom subs
Jeez.
in your bathtub. And this person, it was just pouring out of her mouth. So
I have never seen that. I've read about fulminating.
yeah,
but I've
seen
never
it twice
seen
in
it.
25 years.
Gee, oh wow.
So what we can do for these patients is in the short term, we give them some oxygen, try and help get as much oxygen in the bloodstream.
Absolutely.
We also give nitroglycerin.
Yeah.
Now remember, when you take nitroglycerin, don't chew it. It'll blow your face off.
Okay, I'm going to tell that story. So Franco and I, as you know by now, we were partners. And so yeah, nitroglycerin.
Work partners.
What's that?
Work partners.
Yeah, work partners. Oh God, there's another story of that too. Remember the U-Haul? All right.
Go on with the story.
Yeah, different story for a different day. But yeah, we go on scene to a guy having chest pain. We commonly give nitroglycerin to patients having chest pain. And this particular form of nitroglycerin is a tablet that dissolves under your tongue. And so Mark gives it to the guy.
Completely non-explosive.
Yeah, no, it's not explosive at all. Yeah. He gives it to the guy. The guy puts it on his tongue, and Mark just says, okay, just let it sit on your tongue. Don't chew it. And the guy says, why can't I chew it? And Mark deadpan stares his chest pain patient in the face and says, sir, it's nitroglycerin. It will explode. And this guy immediately, Mark expected, because the guy was actually fairly jovial. He wasn't, I mean, it wasn't like Mark was looking at someone fearing for their lives and figured, well, now's a good time for a joke.
Right.
But
I tend to read my audience a little bit better than that.
Yeah, except this guy literally got scared for half a second.
Well, I can over deadpan things sometimes where, I say it so seriously sounding that people, well, tonight, as we were coming in here about the chai latte, you actually thought I was upset about the chai latte you had told me about 5 minutes earlier.
Yeah, Mark came in, asked if I had any tea. I said I got chai tea. And I went and looked at his, I'm like, hey, sorry, it's a chai latte. He's like, yeah, that's fine. So he walks into the room and he goes, dude, this tastes like a chai latte. I'm like, but oh, never mind. Yeah, totally.
So we give nitroglycerin because nitroglycerin will dilate the arteries and the veins in the body, thereby giving you more room to relieve that back pressure.
Yeah, more room that's not in the lungs.
Right. So the benefit of this is, and it's a short-term fix. We're just trying to get the lungs opened up, try and flood the body with oxygen so that hopefully they can catch up with oxygen. Their cardiac output can increase, everything like that. More long-term, what can be given is a medication called Lasix. What a lot of people refer to it as a water pill.
Makes you pee.
It is a diuretic, and I had this conversation with my partner today whether it was a diuretic or an anti-diuretic.
I mean, I know the answer to this if that was a question.
We took a little more explanation for him.
Okay. Mark is a trainer. He's a field training officer. He trains people in the field. So that might explain the knowledge
This
of
was
his
just
partner.
This guy is actually very intelligent and was just having a brain cramp moment. So
Oh yeah.
So what that's going to do is the diuretic will make you pee. So that is actually more of the long-term fix. Let's get the fluid off the body. People with severe congestive heart failure are generally put on a fluid restriction along with a daily Lasix dosage. Then also what can be happening if it gets severe enough, they will go with what's called an LVAD.
Yeah. Boy, that's bad news.
Yeah, an LVAD is a left ventricular assist device.
It's essentially a robot that squeezes your heart for you. Because your heart
pumps your blood for you and makes you a vampire.
Explain.
You have no pulse.
That's true. You don't.
So the reason you have a pulse is every time your heart contracts, it squirts blood through your arteries. Yeah. And that's what you feel is your pulse. This is a constant flow system. So there's not that pulsating. Yeah. So you will talk. This person will be sitting there talking to you, and they won't have a pulse.
Yeah. Now they
blood's
will have
flowing.
What's that?
The blood's flowing. They're actually alive. It's just you don't feel a pulse.
You can actually oscillate sound though. If you use a stethoscope, you can actually place it over several points where arteries are, and you will actually hear a running water, I guess, type effect. Actually, former Vice President Dick Cheney was on an LVAD.
Was he really?
Yeah, he was, because he had a severe heart condition. That's actually one of the little-known things. I actually saw an interview with him. He, at the White House, he had a resignation letter ready to go at all times because his heart was in such poor condition.
Wow.
Yeah.
So, go ahead.
Oh, no, go ahead.
I was going to say, well, the LVAD is a short-term stopgap until you can get a heart transplant.
You need a new heart. That's not going to last.
What's happening is your heart, every time it beats, and we're talking a lot about heart considering this is a respiratory show, every time it beats, it will put out a certain percentage of blood that's in the chamber. It's called your ejection fraction. Generally, people who go on LVADs have a less than 10% ejection fraction, unless there's something to put them on there above 10, less than 10%. So, yeah, this is until they can get a heart transplant. But it restores some of their quality of life because they can get out and do certain things. But it's a very high maintenance system.
Yeah.
So CHF, oxygen, nitro, some Lasix, and try and take that fluid off of there.
Now, we also give another treatment. Should we talk about CPAP, or do we talk about that a little bit later?
Let's go with about CPAP. Why not?
Okay. So CPAP, if that sounds familiar to anyone who has, who snores at night or has
sleep apnea.
Sleep apnea. Thanks. I don't know why that was evading me. It is. It stands for continuous positive airway pressure. And that's just a mask that fits over your face that literally makes the atmosphere around your mouth a higher pressure. Because the way you breathe, all you're really doing is you're opening up your lung sacs. You're opening up your lungs to where there is now more space in the lungs, thus dropping the air pressure. So the air pressure outside of your body is higher, air flows in. So what this is doing is that if you have trouble getting air in other words, your lungs have too much resistance, you put on the CPAP mask and it just creates a lot of pressure. So when you take in that breath, that air is essentially just shoved right down your airway and helps get air where it needs to be. We use CPAP for the treatment of congestive heart failure as well as COPD. And the reason we do this is because in the event of, well, let's just talk about congestive heart failure. Earlier, Mark had mentioned that one of the problems is that the heart, the pump with the blood, isn't able to produce enough pressure to move blood out of itself. And so blood gets backed up. And one of the places it will back up into is the lungs, because the lungs have a reduced pressure compared to what's in the heart. So it can actually push that direction. You put a CPAP mask on and that increases the pressure in the lungs and pushes that fluid back to where it needs to be, allowing you to actually get air to the surface of the alveoli.
And also what it'll do is while you're exhaling, it will hold those things open a little bit so that you're not having it collapse all the way back down again.
And actually, if you don't, you've actually probably witnessed that people with COPD, specifically people with emphysema, will try and create that pressure. If you ever actually see someone with emphysema, or if you have a relative or you do, they'll sit down and they will actually purse their lips and blow. And that actually increases that pressure and helps actually expand some of those alveoli down there that have collapsed thanks to emphysema.
Right. Sound unhealthy, man. Keep smoking.
See, and here's the thing. I have never smoked in my life. I mean, okay. That's not an entirely true statement, but I have never smoked regularly in my life.
Did you smoke irregularly in your life?
Yeah. I mean, like a cigar at a wedding kind of guy. That's me.
Okay. Those bong rips you did in the Caribbean. Okay.
I mean, we're recording, so we'll fun.
Moving along. So you have what's called ARDS, ARDS. Chris, tell us everything you know about ARDS.
I was really hoping you were going to take that one.
So ARDS is an inflammation of the lungs. It's usually brought on by trauma, pneumonia, sepsis, and it's basically something external is acting upon the lungs, and it causes your lungs to internally become inflamed.
What does it stand for?
Acute respiratory distress syndrome.
That was literally my guess. I mean, I know what I know of ARDS, but or maybe you don't.
No. I'm you're talking. I was just giving you a second. Acute respiratory distress syndrome. Yeah, that's exactly what it means. It can also be called respiratory good Lord, respiratory distress syndrome, adult respiratory distress syndrome, shock lung.
Shock lung sounds stupid.
Sounds like a band name.
A band name. See,
shock lung.
See, to me, it sounds like the world's weirdest superheroes, like super move. I gotta do it, Johnson. No, you can't.
Give him the shock lung.
But you can only do that once.
Right, that's a one-shot deal, man.
Shock
No, see, I hear it more as like, Blink 182 with opening band, shock lung.
Yeah, I can see it. Like definitely like a logo band.
Right.
That's like just kind of
it's here for one night. So
yeah.
Anyway, acute respiratory distress syndrome. So yeah, this is an inflammation of the lungs. It can cause fluid. It's caused by fluid retention due to an external shock of some form. Okay, we also have pulmonary embolus.
I thought the P there was for physical education. I'm like,
right.
I don't want to revisit that.
Physical education can cause shortness of breath in the short term.
Yeah, absolutely.
So this instance, it stands for pulmonary embolus. What this is a clot that's in your lungs. Mm-hmm. Your body produces clots all day long.
Yeah.
Your liver is job. Yeah, it is. As you bump into things, you get bruises. As your body's repairing itself, you have clots. Your liver is very good at cleaning these out. Your liver and your kidney, your renal system. But occasionally some will get through. In a PE, you have a clot forming and it's blocking a major artery if it gets bad enough. So you're not able to cause blood to flow through that part of the lung. And it can actually cause part of your lung to infarct or die. If it gets bad enough, it can actually cause cardiac arrest.
The hard part about pulmonary embolisms for us is that it's difficult to treat in the field.
We really don't have a direct treatment other than treating the symptoms.
Yeah, really. I mean,
giving them oxygen, breathing for them, doing CPR.
Yeah, and if the PE is big enough or there's too many of them, that's the problem with the PE. I mean, you can sit there and shove all the oxygen in the world you want. If there's embolisms blocking that gas exchange from
blocking the blood from getting to the alveoli,
then it doesn't do any good.
Never tell you I thought alveoli sounded like an Italian shampoo.
No, but it does. I would have gone with like an Italian.
I use alveoli.
Yeah. This is one of the things what we eventually we should do like a video stream as well.
Right, yeah, we should.
Because we're actually watching you. Well, okay. Watching Mark, to me, is actually one of the funnest things ever.
Yeah, but the thing is, let's face it, Chris, we both have faces for radio. None of us are good. Neither of us are good-looking men.
We're not awful looking. We're charming, I think.
Yeah, we make up for it in personality. Don't get me wrong. But, yeah. So... Yeah, with a pulmonary embolus, what you end up having to do is you end up having to go on an anticoagulant. If it's severe enough, they may go in and pull, although I saw a gnarly video the other day, Chris. I have to find it for you. They were pulling out a huge pulmonary embolus out of this guy's lung. Wow. I swear it was 6 inches long. Looked like a slug. Jesus. Yeah. I mean, to the point that my partner, another paramedic, is like, and I'm no longer hungry. It was amazing how big this thing was. Oh, geez. So, yeah, it's a pulmonary embolus. So a lot of times what they do is they'll put you on a heparin drip to start breaking down the clot. And then they will put you on a warfarin dosage, and they'll keep you on the heparin until your warfarin dosage becomes therapeutic. And then you're probably going to be, if they don't have a direct reason, and there's many reasons you can get one, Patients who have had surgery and have been bed confined for a long time, and so they have pooling in the blood in certain parts of their body. Patients of severe trauma, your body's throwing a lot of clots because it's trying to repair a lot of things. And then sometimes there's just a big question mark, which is what it was for me when I had my PEs. I had two very large PEs, and we don't know why I got them. I'm an active guy. I hadn't been having any surgery. I hadn't been bed confined. I hadn't been on a trip where I've been sitting in an airplane for 8 or 10 hours.
I remember that. It was actually it's kind of scary.
It was very scary.
Yeah, probably more so for you than us. We don't like you that much. But I mean, like in general, if it could happen to someone who really has no good reason to have them, it could happen to us.
Right.
That's why it's scary.
Yeah. Well, it's all about Chris. So,
Yeah.
So, like myself, I will probably be on a blood thinner for the rest of my life.
Yeah.
Because of this, because I don't want to get back to the point. Of course, the way I ate McDonald's, that won't be a long time, but,
God, but it's so good.
It is. So, yeah, pulmonary embolus, clots in the lungs.
Yeah. So next, let's talk about another disease, particularly nasty one, cystic fibrosis. So cystic fibrosis is a genetic disease. It starts when you're born, essentially. And what it is it's a progressive genetic disease that causes persistent lung infections, and it limits the ability to breathe over time. So basically there's a defective gene, and it causes this kind of thick, sticky buildup of mucus that's always present in the lungs. It's also around some other organs as well, but the lungs is sort of the one that ends up dominating somebody's lifestyle. It eventually will lead to respiratory failure. And of course, if you have respiratory failure, you pass. Cystic fibrosis used to mean a fairly early death. Basically, you weren't expected to live past your 20s. If you got into your 20s, that was going a long way. In the past 3 decades, though, we've had some significant improvements to where it's about 37 and a half years, although it's not unheard of to see people living into their 50s either. I actually recently had a patient who had cystic fibrosis, and he thought that, you know what, I got cystic fibrosis, I might as well smoke. And this is one of those guys that defies logic, where by all means, he should have been the cystic fibrosis patient that didn't make it into his 30s. Somehow he's 50s, cystic fibrosis, and a smoker. Now he also has COPD. I was the last paramedic he saw, if anyone's catching my drift. But yes, that was a call that I ran.
So he suddenly became healthy and no one could call 911? Is that where we're going with this?
Not at all. No, not at all. The smoking cystic fibrosis patient unfortunately ended up passing. Do
you remember we had a patient in county who decided or had researched, finger quote,
yeah.
I feel I should probably go ahead and give credit to the guys on stuff they don't want you to know for the noise for finger quotes.
Right.
Decided that smoking marijuana was the best way to treat his asthma.
Yes. No, I can tell you his name too, but I won't.
Yes.
I won't. But yes.
I heard he passed.
Did he?
That's what I talked to Fire the other day. I asked about
it. Bong in his hand trying to treat his asthma.
Oh my God, we ran. He was so critical every time we ran him.
I did an EJ on that guy.
Wow.
Yeah, it's the second EJ. Well, no, I've done 2 EJs. That was the first EJ.
I gave him more epi than probably, outside of a cardiac arrest, any 10 other patients I've ever given combined.
Well, because by the time we got to him, I was running with one of the larger fire departments, and we're kind of looking at this guy, and the firefighter I was with, I've worked with him many times. He's better at IVs than I am, and he's sitting there like, dude, I got nothing, and looking down at the arm. So it's one of those moments where I'm like, crap, because if he doesn't have anything, I don't have anything.
Right.
And an EJ stands for external jugular. That's basically where we take a needle and we stick it right in the jugular, because it's the
vein that runs down this outside of your neck on both sides.
Yeah, and so
it's kind of a last resort IV for us because they can be tough to stick.
Yeah, well, they can be tough to stick, and then you do have some other concerns as well, is that they tend to have a harder time healing because they are such large vessels, and their veins. Veins are not like... oh, gosh. Well, they're veins, and you can form clots in them as well. So sticking a large vessel like that is a last resort. And it's one of those things, though, where you stick it like, well, if I don't stick it, he's probably going to die. So let's go for it. So we did, and we got it. And the problem was he was so sweaty that once you get the IV,
Yeah.
it's really hard to tape it down on the neck, and you can't just get out Coban and wrap it around
Right.
the guy's neck.
Coban is a piece of equipment. It's a constrictive bandage.
Yeah, so if you had like an IV on someone's arm and they were really sweaty, Coban would be perfect because you can wrap it around their arm.
And it sticks to itself.
Yeah, you don't have to worry about
Holds everything in
sticking
place.
the patient. Right, but
Don't want to cut off the airflow to the brain.
yeah, wrapping a constrictive band around someone's neck. It probably wouldn't squeeze hard enough to cause any damage.
But it would definitely cause a claustrophobic feeling, I think.
Yeah, I just couldn't imagine walking to an ER with a constrictive band
Right, yeah.
around the guy's neck.
Be a lot of explaining there.
Yeah, so we gave that guy epi and it helped. But yeah, I'm a little sad that he passed because I think
he was a nice guy.
Yeah, and once we were able to get treatments on board, he responded fine. But the problem was that he wouldn't take his treatments.
He would not stop smoking pot.
No, that was just his. And that's actually one of the things that I came across to in preparation for this episode. They're talking about smoking, and they do mention that it's not just tobacco products, it's marijuana too. And and it really doesn't have to be marijuana. The problem is it's smoke in the lungs.
Right.
And the lungs get irritated over time.
Camp smoke, marijuana smoke, cigarette smoke. The difference is how much you smoke.
Yeah. Exactly.
Marijuana smoke, from what I understand, is actually worse for you because it's not filtered.
Right.
But you don't smoke as much of it. It's like cigars, just as bad for you, or a pipe, just as bad for you. You just don't smoke as much.
Yeah, versus cigarettes, you got 2-3 pack a dayers.
Right.
So, which I'm sure someone out there's like, part of the day.
Yeah.
But
so anyway, back to cystic fibrosis.
Right. So anyways, so cystic fibrosis, it's a very deadly disease. It's something that kind of stuck with. There is no cure for it. But yeah, it's this thick buildup of mucus. Kind of some of the other oddball kind of symptoms that it has. Just kind of reading my list here. Very salty tasting skin. And I actually remember listening to an instructor once.
Don't check that on scene.
Yeah,
don't check that on scene.
Well, no, that's why I bring this up.
Don't check that in the ambulance. Don't check that at the ER.
Don't check it,
Don't
period.
lick your patients.
Well, it was one of the things that they were saying. There was this instructor once that had a habit of maybe saying things that they didn't really know. And kind of like us, except...
Who found that out? Who was the first person to look
That's
at
what I'm
cystic
saying.
Yeah.
There's one guy that checked it.
Yeah. And then went, hey, that guy's kind of salty tasting. But the thing is, that means he knows how other people taste. So he's not just licking the cystic fibrosis people. He has like a control group going on where he knows what normal people taste like, how salty they are versus a cystic fibrosis guy.
So I will say this wouldn't be too terribly hard to come across if you're a bit of a ladies' man. And then one day somebody's like, oh yeah, I have cystic fibrosis. And you're like, oh.
That's really probably the most legitimate way to find out this thing.
I was going to say it's less creepy, but we're editing this part out.
Maybe.
Maybe.
So.
Anyway,
back to the legitimate medical science.
Right. As far as us kind of diagnosing or treating it in the field, the only things that we can really do in the field are give our bronchodilators, which is asthma. That's the main thing that we're going to use to be able to help a cystic fibrosis patient. The problem with cystic fibrosis patient is, again, they got that thick, sticky buildup of mucus, and it's not just like your everyday kind of bronchitis mucus that, hey, if you cough hard enough, it'll come up, or take some Mucinex, that'll loosen it up. It's almost like a thick, tarry substance, and it's caused by, I think it's like a defective protein or something that your body has, and it just makes a very thick, sticky mucus
that you can't get out. So as it builds up, you lose the ability to exchange oxygen to your bloodstream.
Yeah, and there's just not much we can do out of the field aside from trying to widen the airways a bit.
Again, treat the symptoms.
Yeah.
So, okay, so we're going to go back to some lung sounds. Chris has played a couple for you.
Here, I'll play it. This is actually what normal lung sounds sound like. So if you're just going up to any patient that doesn't have a disease process going on, you can hear a sound kind of like this, kind of like ocean waves. I would like a white noise machine like this, I think. Nah, I'd hate it. Anyway.
So you have rails, which we've covered, and this is liquid in the lungs. We can also have what are called crackles, which is less liquid in the lungs, and it sounds like a crackling sound. Then we have wheezing, asthma, and emphysema.
Yep, here's the wheezing sound again. You can hear it at the end. And by the way, those are all sounds that we would hear through a stethoscope. Not necessarily as you walk into the room.
Sometimes you can.
But you can, absolutely. Right. That's
well, then one thing my paramedic instructor told me about emphysema and asthma was that Not all asthma wheezes, and not all that wheezes is asthma.
Yeah.
And so you really have to do a differential diagnosis on these patients to make sure you're going down the right path.
History is really important.
It is.
History is very
Well,
important.
if we don't learn from it, Chris, we're doomed to repeat our failures.
Medical history of the patient's really important.
Ah, yes, that makes a lot more sense now you say it out loud, man.
So the wheezes is caused by, as Mark mentioned, this is something we hear in typically asthma patients, but it's basically caused whenever you have a narrowing of those airways that we talked about.
Right.
And it's the same way as you whistle in real life. You purse your lips and blow.
Right.
This is the same story. We're just making a smaller airway and blowing.
Anyway, so we've talked about rails. So the last one we're going to talk about real quick is rhonchi.
Did I actually tell you that I didn't learn to whistle until my 20s? Doesn't
surprise me. Anybody who's seen you catch a baseball has no doubt about your slow development.
All right, hey, no. I got to back that up. It depends on the day, man. I'm either Ken Griffey Jr. or I am substantially not.
No, it depends on the day whether you can either throw well or catch well, but you can't do both at the same time.
Yeah, the brain's only one half of that brain. Actually, probably the same
and
side.
Don't forget, you cannot catch underhanded.
So, there's a story there too. So
do we really want to tell this?
Yes. I mean, it's me getting hit in the nuts with a baseball. That's pretty much the punchline of the story, but yeah.
I stand corrected. Go
ahead. So pretty much, if the ball is thrown at me and it's below like shoulder height, I pretty much have to stoop down and either catch it above my head or catch it just kind of standard grounder style if it's that low. So one time Mark throws the ball, we're at a post, and it's just kind of something to do to pass the time, and he would bring baseball, a couple gloves, and we're just throwing a ball. And if we didn't have a ball, we'd throw a sailing bag. Remember when we had our intern?
Yeah.
But anyway, the boss isn't listening. But anyway, so yeah, he's throwing this ball, and one time he throws it, and it's like this perfect throw where it's gonna be a grounder right at my feet. Like it's just like this perfect arc. Like you should have been like an artillery officer in the military. I don't know why you did this.
I nailed the azimuth.
Yeah, exactly. So I stoop down to catch it. It goes past my glove because I'm slow, and it bounces right in between my feet, straight up, and just teabags me.
Yep.
I mean, just
or you teabagged it.
Well, yeah, exactly. Just hits me right in the jubilee. And so I kind of double over. Mark's laughing.
Yeah, I would like to say I ran over to make sure that my partner was okay.
You didn't, and you never asked if I was okay.
Oh, you were fine.
Yeah, I know, but a lot of people joke. It's like, oh yeah, I mean, I'd laugh first, but I'd ask if you're okay. He didn't even ask. It never got to that point. He's just like, yeah.
Yeah, but in all fairness, you're also talking to the guy who locked you in every outside compartment in an ambulance.
A little more
your well-being really important to me?
No, it's not, but it's not important to me either. It was pretty willing on those. So, of course, we need to write up an incident report. That's an employee injured on duty.
Right.
And so we write up an incident report, and Mark and I both have some distinct physical features. Mark has a fairly epic mustache. He's a broad-shouldered man. He's just a large dude.
And I wear glasses.
And he wears glasses. So I draw a broad-shouldered man with a mustache.
Stick figure with broad shoulders, mustaches, and glasses, and writes...
Unknown assailant is his title. And then there's me, and I drew the nutsack. We handed it to our supervisor.
Well, you drew a dotted line trajectory
of
where the ball went, and then had a stick figure of somebody squatting with a label and an arrow pointing to the testicles.
Both stick figures were wearing gloves, by the way.
Yes.
That's the best part. So it's like I was wearing a glove randomly, and I'm an assailant also wearing a glove.
Right.
So we handed it to our supervisor, who promptly ground filed it, but still, it was worth it.
Yeah, good times.
All right.
So the last lung sound we're going to have is called rhonchi. This is similar to rails in that it is a buildup of mucus in the lungs instead of fluid. Now, the best way I tell people how you tell you the difference between rails and rhonchi. Sometimes you can't.
Right.
Sometimes you have very liquidy rhonchi. When it's thicker, how I describe it is if you're blowing air through pudding.
Yeah, that's good.
That's what it sounds like. Is if you have a straw and a bowl of pudding, you just get that blop, blop kind of noise. That's what rhonchi sounds like. So.
See, I always compare it to like I don't know if this makes any sense, but to me it always sounds like wet Velcro.
Yeah, I can see that.
Yeah. He's kind of got, this kind of almost little cracks, little pops. And
yeah.
Then you've got kind of this wet sound.
So, yeah, those are your lung sounds.
Right.
We've gone over some of these medications. We have the albuterol and the Zopanex, which are two different forms of albuterol. You have the Atrovent, which we mix with the albuterol. I don't think they mix. Do they mix Atrovent with Xopenex? I don't think so.
I have no idea. I've never heard of it, but I mean, crap. I'm going to look it up really quick.
We've talked about the Lasix, a diuretic, and we've talked about nitro, the nitroglycerin for expanding the vasculature. And then, of course, the ever-present oxygen. You know, we really... Oxygen is something that, for many years, was give it as much as you can.
Yeah.
Just load patients up on oxygen. And they've really gotten away from that.
Well, yeah, I mean, I can remember, I'm a little bit closer to school than some older people in the room, but even I can remember that in school, pretty much they just say, always give oxygen. You'll never fail your test if you give oxygen.
Right.
Yeah.
And still that way in the testing scenario. But out in the field, they're actually looking at reasons to not give oxygen. Your emphysema patients, if you give too much oxygen to for too long, you can actually knock out the respiratory drive. Now, this is talking multiple hours. And the reason being is that, so if you're a healthy adult or a healthy child and you go out and exercise, your respiratory drive is driven by how much carbon dioxide you have in your bloodstream. So as your carbon dioxide level goes up, your respiratory drive goes up because you're trying to blow off that carbon dioxide and you're trying to intake more oxygen.
So going back to whether or not Xopenex is ever mixed with Atrovent, sorry to go back there. It looks like it's been done, but it is not common because they do have a study on it where they attempted to see if it would be helpful.
Right.
Their hypothesis is that it was. Their conclusion, actually, it looks like it's still going on. There's no conclusion yet.
So, don't know.
Yeah, don't know yet. But yeah, it's nothing I would say is terribly common.
So, with an emphysema patient, in a normal human being, your respiratory drive is driven by your carbon dioxide levels.
Right.
With a COPD patient, because of all the carbon monoxide you put in your bloodstream, it's actually destroyed your body's ability to run your respiratory drive that way.
It's funny. This actually probably goes against a lot of conventional wisdom. I think a lot of people out there believe that, I want to breathe more because I'm deprived of oxygen.
Right.
Really, your body wants to breathe more because it wants to get rid of all the built-up CO2.
Right.
Yeah.
It's trying to bring everything back into balance. So with a COPD patient or an emphysema patient, what's happening is your body runs off of an oxygen drive system.
Yeah, which is different.
Which is different. So if you flood them with too much oxygen for too long, they will actually slow their breathing down to the point where they'll stop breathing.
Right.
And it's very difficult to wean them off of oxygen at that point. It takes weeks in an ICU for them to slowly turn down the oxygen. Because it doesn't work quickly enough that if you just take them off oxygen, they'll start breathing again. At that point, the respiratory drive has been knocked out. So you have to take a long time to slowly wean them off of the oxygen.
In the meantime, they're on a ventilator that does the work for them.
Exactly. So, anyway, anything else you can think of, Mr. Fingston?
The only thing I think I'd want to talk about maybe is spontaneous pneumothorax.
Yeah. Oh, yeah. Pneumothorax. I didn't even think about that.
Yeah. So,
or even spontaneous, also traumatic, tension.
Yeah.
We should probably go into those also.
Yeah, so a pneumothorax literally means air in the thorax, which is your chest.
Not to be confused with a hemothorax, which is a similar sort of problem, but it's blood.
Yeah, or the lorax, which is actually a Dr. Seuss character.
Right.
That's a very Frankum joke I just said, by the way. I hang out with you too much. Yeah, so pneumothorax is essentially whenever you have a pocket of air that's between the lung and the chest wall. And there's a few ways that can happen. I'll just go over the traumatic ways. So if you take typically like a blunt force or even, I guess, penetrating trauma to the chest, what'll happen is in the case of like a blunt force trauma, like a baseball bat, you'll have the lung itself, the lung tissue will rupture and you'll get air that will escape from inside the lung that will actually get out of the lung and get between the chest wall.
Now, is this because of a fracture to a rib or because of a paper bag effect?
Paper bag effect?
Where you take a breath in and you have trauma and it causes your lung to pop like a paper bag.
Not sure what you're talking about.
So if you take a big deep breath and you fill up your lungs with air, and then you take a blunt force trauma, a lot of times it's in a car wreck.
Okay,
there's not enough time to get the air out of the lungs, and so it'll compress the lungs and the lung will actually pop.
And what is the first thing you do when you see a trauma coming your way?
Exactly.
Yeah, so you do that. Okay, I see what Mark's saying. Yeah, sorry, my bad. Slow today.
Sorry, who was closer to school? Maybe somebody should go back.
I mean, who's getting schooled? It's me. So I guess I would still be closer to school at this
That's
point.
a good point, yeah.
Yeah. Yes, I kind of won that argument.
Not really. Just move along.
Ultimately, I'm the loser. But yeah, so what ends up happening is you get that air kind of forming in there, and as that air pocket gets bigger, it starts to collapse the rest of the lung. And of course, a collapsed lung isn't good for taking in a volume of air. Now, if you get too much of an air pocket in there, it actually starts to create tension. And this is what we call a tension pneumothorax.
Pneumothorax.
I know, you just coughed right into the mic.
Oh, did it? I'm sorry.
Yeah, no, it's all good. So, God damn it. I've been holding it in for a while. That was just my relief.
Respiratory stuff.
Yeah, right? You heard it first. So anyway, so a tension pneumothorax is when that pocket of air between the lung and the chest wall starts getting so big that it starts putting pressure on the mediastinum, which is a fancy word for middle of the chest, near the sternum, where your heart sits. So essentially what you have is the heart has its own little happy home right there in between two lungs. One of those lungs is popped. It's putting a lot of air in between the chest wall, and it's squeezing all that stuff onto the heart and the greater vessels that return blood and take blood away from the heart. And what this will result in is a reduced cardiac output. So if Mark's CHF was a heart problem causing a lung problem, this is a lung problem causing a heart problem. So now not only do you have a person who cannot take in a lot of air because they have one essentially popped lung, you also have a heart that can't push out a whole ton of blood because it's being squeezed by the air that's escaping out of that lung. So one of the ways that we treat the way that we treat this, actually, we treat it in the field. It's a rare intervention. We don't do it a whole lot. That being said, I've done it twice.
I've never done it.
You've never done it?
I've never done a chest decompression.
Gosh. Well, maybe just
I don't allow my patients to get to that point.
I will say, I did it twice on one guy. If that's...
So is it because he got it wrong the first time?
No, actually, that's, I'm going to tell that story now. So this guy it's actually kind of a sad story. He's in his 20s. He was driving home from work as quick as he could. He was around like a horseshoe turn and just left the road, and he hit a tree, and he kind of horseshoed around that tree. And the middle of that horseshoe, that bend, driver's side door where he was at.
Oh, wow.
Yeah. So this is actually my second day as a paramedic.
Wow.
Yeah. I'm going to edit this part out. Senior was Chuck Short.
Yeah, definitely edit that part out.
Yeah. But anyway, so lots of trauma. We pull the guy out, and I'm a new paramedic, and I'm kind of excited to do some interventions and that kind of stuff. Also a little bit freaked out because it's really serious. And when you're on your internship prior to this, you got backup. But now it's me. It's go time. And of course, it's out in rural Forest Grove. So we have volunteers who aren't, they're
not as experienced.
No, they're not. I mean, they're experienced, but they don't have the same level of certification I do at this point. So I go to intubate this guy, and part of intubation is you have to stick a tool in the person's mouth and take a look at their airway. You have to look at the trachea, and I see the trachea, and then I do a rookie maneuver, and I take my eyes off the trachea to retrieve my tube. And by the time I look back, trachea is gone. I'm like, shit. So we end up dropping another device called a combi tube. More on that later. But we put in a different airway device, and then I take a look at this guy's trachea from the outside, where I can just, trachea is the windpipe, where you can just see it. He's a slender gentleman, and it's deviated. It's actually moved to one side. Well, if you remember that pressure I was talking about that's going to be pushing everything to one side, well, it's going to push everything to one side. And what you'll see is the windpipe, which is connecting to the things that it's pushing, is going to follow it. And I immediately, the little paramedic student in me is like, oh my God, it's tracheal deviation. That means there's a pneumothorax. Oh my God. And I strip the guy's shirt off. I palp his chest, and you can actually feel the air permeating the skin. And it feels like a bag of Rice Krispies.
Subcutaneous emphysema.
Yes. And what we start doing is I start pushing on that. I'm like, I know what this is. It's time to decompress. And so luckily my partner was like, look, man, go for it. I don't know if it was because he didn't want to be the one responsible, or if he had done it before. So anyway,
we all know the answer to that.
Yeah, right. So decompression is essentially We take a needle, it's a long needle, it's a big needle, and we stick it right through the chest, right to where that air pocket should be. And then that pocket of air goes out that straw, and then it allows the lung to reinflate and takes that tension off. There's a couple things, though, that can, let's just say, make that difficult. God, but there's a C word. Complicate. Jesus Christ. There's a couple things that can complicate that and make it worse. One, if you've taken a large amount of trauma, chances are there's not just air in there, there's blood too. And when you pop that needle in there, you now have blood mixed with air pressure suddenly found a way out. So everyone who had gathered around, and this was before, I would say eye protection right now is, everyone's talking about eye protection for paramedics. But when I started, which wasn't terribly long ago, eye protection was that thing we all knew we were supposed to do, but didn't do regularly. And I was the only one wearing eye protection. Everyone else, of course, wanted to see what is a very rare intervention and was essentially sprayed in the eyes by this guy's blood. Anyway, so what ended up happening, though, because this guy took such severe trauma to the chest, he actually had a substantial enough, he actually had essentially that popped bag effect as well on the other side of his chest, too, on the other lung. However, the tension from the larger one, the one that I decompressed, had kept that one at bay. It was actually literally applying pressure on the other lung and did not allow the air to escape that lung and create a larger pocket there. So the moment we popped one side, we were able to bag him again, using a bag valve mask device. We were able to inflate his lungs just fine for a little bit, and then all of a sudden it became difficult again, and then his trachea actually deviated the other direction. So now we had a pneumothorax that formed on the other side. We decompressed that at the same time. A local air ambulance, local helicopter had landed, and their nurse had begun starting a chest tube on the other side, which is to allow blood to drain, of which there was a lot. And then he went in a helicopter and flew away.
You make it sound like he was flying the helicopter.
Yeah, I mean, gosh.
Yeah, well, you fixed a lung problem, so apparently he's fine to fly.
Yeah. He died later. But.
So, yeah, it's pneumothorax pneumothorax can be a potentially deadly situation. Now, you can have what's called a spontaneous pneumothorax, which is a similar effect. Generally, they don't get that bad. They self-resolve. And one of the defining characteristics of who are at risk for a pneumothorax, tall, skinny males.
Me.
Yeah.
Smokers as well.
Yeah. Now, do you know why tall, skinny males? And I ask because I don't know why, because I'm not skinny. So I figure I'm safe.
I mean, I could take a shot in the dark, but I don't really know why, no.
Figure you would.
Yeah,
Being
I
at
think
risk
I would,
for
but,
it, that would be tall, skinny. Talk while I look this up.
I just kind of want to go back to, because you're sitting there saying that you figure I would. Let's reiterate, I let you shove me into literally every compartment on an ambulance. Point. There was actually, so to go back to that reference, there are many, 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 many compartments on an ambulance. And one day, Mark and I got it into us that we need to figure out how many of these I can fit in. And I'll have you know.
It came from you fitting into the oxygen bottle compartment and us scaring that VST.
Yeah, a VST is a vehicle service tech. They basically, they get the rigs ready to go the next day. And so...
Oh, hey, you're safe. It's tall, thin, adolescent, man. You're no longer an adolescent.
Yeah.
Chronologically.
Right, yeah. But yeah, what we did was they change out. What they do is they also fill up the oxygen mains in the ambulance. It's just large oxygen tanks, so we have oxygen all day. And I just went ahead and hid in that compartment. And then Mark tells the guy, yeah, we need to change out the oxygen main. So the guy, of course, opens the compartment. I pop out. That guy looked like he was ready to fight. He jumped like 3 feet back.
And he probably should have. In all fairness, he probably should have punched both of us very hard.
Yeah, absolutely. And honestly, you can't critique a guy for having that response. It's actually supernatural.
Yeah.
That's kind of...
So that led to, well, what other compartments do you fit in?
Oh, of course. Which turns out all of them.
On that particular ambulance, all of them.
The hardest one was the very, very small one above the exhaust pipe.
Right.
Not only did it smell so pungently of exhaust, it hurt to get in there, especially when you close the door. And then that was the only time where it really sunk in just how much I'm relying on you to
right. Well, because the problem was with Chris in there, he was pushing against the door, which put friction on the latch, which made it exceptionally difficult to open the door.
Could you imagine?
So
calling
Chris
the fire
asked, so
department?
what would have happened if we'd gotten a code 3? And my response was, well, we would have gone to the call. So imagine that kind of terror where we're driving code 3 down the road. You're in a confined space and you can't get out.
It's painful, by the way, too. It's not easy to be in there.
And you can't get out unless the door happened to spontaneously open while we're driving code 3 down the road.
Which it could have.
You know, so...
Could you imagine? I would just... The only thing about that, though, I would love to be able to tell the story. And then we arrived on scene, and they're like, where's your partner?
Right.
And I'm like, oh, he's stuck in there. And so while Mark treats the patient, they're out there extracting me from the damn ambulance.
Or even better, where's your partner? I walk by. Oh, he's right here. Pop the door open.
Yeah, absolutely.
And you climb out.
Yeah.
So,
that would not be climbing out. I'd be rolling out, cussing my head off at you. And then
now,
proceeding
in
with
all
the call.
fairness, be funny up until they fired us.
Actually, it'd be funny after
And
that.
it would
There'd
be
a
funny
brief
too,
period of
but
time.
you know, I don't think the company would see the same level of humor in it that we would.
Especially not like right now.
No.
Yeah.
Yeah. So, anyway, anything else, Mr. Frankston?
No, man, I think that kind of wraps it up. We're right about an hour. So.
Yeah. So, thank you for listening. Thank you for supporting us. Hopefully, we are educational and entertaining all at the same time. And until next time, this is Medical Stuff.
Bye.
Bye.
Toast.
Toast.
Shit, where's the off button?